So we are at this level here on the arteriovenous transition, focal diseases, vein of Gale, and arteriovenous malformation. This is the outline of my talk. We will start off with a little bit of the epidemiology. Vein of Gale and arteriovenous malformation are arteriovenous malformation of choroidal vessels that drain into the precursor of the vein of Gale, and the precursor of the vein of Gale is the median prosencephalic vein or the vein of Markowski. Because the feeding vessels are choroidal arteries and the draining vessel is the median prosencephalic vein, we know that these malformations have to occur sometime between the 6th and the 11th week, because after the 6th week of gestation we have choroidal vessels. However, after the 11th week of gestation we no longer have the median prosencephalic vein, but we already have the normal vein of Gale, and therefore the timing of this vascular malformation is somewhere between the 6th and the 11th week of gestation. It is overall a very rare disease. However, if we look at all pediatric vascular malformations, it's no longer this rare. In fact, it's about 1/3 of all pediatric vascular malformations. And if you are just looking at causes of high output heart failure in neonates, it's the most common extracardiac cause. So, from an embryological point of view, we do know that after the 5th week, we have choroidal arteries. And during these 7th to 8th or 10th week, the choroidal arteries feed into the choroidal plexus that drains into the median prosencephalic vein right here. And by the 10th week, the internal cerebral veins annex the drainage and form the vein of Gale to then drain the choroid plexus. So we do know that sometime between the 6th and the 11th week, there has to be a malcommunication between your choroidal arteries and this vein. And if this happens, then your normal venous anatomy will not be formed. In fact, the arterialization of this median vein of the prosencephalon prevents your internal cerebral veins to be connected to the shunt. And this will now allow us to understand why these patients become symptomatic, because now the internal cerebral veins have to find alternative drainage pathways. And here we can see an example where we have, due to the arterialization of the venous pouch, an incomplete annexation of the internal cerebral veins. They just don't hook up to this pouch. Is this present in all patients with vein of Gale and arteriovenous malformations? No. In fact, we have recently found a few patients who actually do still have a communication of the internal cerebral veins despite a shunt here with the vein of Gale. From an imaging point of view, we will see a dilated median prosencephalic vein right here. We can see that your normal internal cerebral veins in most cases are not interconnected, and we can see massively dilated feeding vessels that always have to be the choroidal arteries. From an angioarchitecture point of view, we will need to discuss feeding artery, nidus, and the venous drainage. Feeding arteries, as I said, always and all choroidal arteries, always bilateral. This differentiates the true vein of Gale and arteriovenous malformation for those lookalikes where you may have a unilateral shunt only. That is not a vein of Gale and arteriovenous malformation. You can have pericallosal supply, and this goes back to our anatomy session from October, where Carl described to you that the choroidal vessels can also be filled through the so-called limbic arch, where we have via the pericallosal artery, the inferior or subcallosal artery, an interconnection to the posterior choroidal artery. And this is the limbic arch. If the shunt flow is very high, then you can get secondarily induced subependymal arteries that you can see here. Now, the importance of these subependymal arteries from a treatment perspective is that they are very difficult to go through. These are fragile arteries, these are neoangiogenic vessels, and they can regress if the shunt is being taken care of. However, if you only ligate a choroidal artery, then it's these subependymal arteries that will take over the supply of the vein of Galen and will make your life extraordinarily difficult, and treatment of these shunts virtually impossible. The choroidal arteries are interconnected with each other, and here we have like nicely seen the limbic arch from the pericallosal artery here going into a subcallosal artery that will interconnect with the posterior choroidal and the anterior choroidal artery. And again, these connections will be of importance when we are talking about the treatment of patients with vein of Galen arteriovenous malformation. You all know that in the moment where you inject glue, the glue will harden or precipitate if it is in contact with unglucosed blood. So therefore you always load your microcatheter with glucose, you inject the glucose and then you inject the glue. However, if you are in a situation where you are proximal to one of those interconnections, then when you inject the glue will harden upon contact of your anastomosis, and you will not reach all the way into the venous pouch, but you will only ligate. And therefore you'll have to understand the anatomy and be more distal. So giving this example here, you can see that the subcallosal artery here interconnects with the posterior choroidal artery right here. Now, if you were with your microcatheter here, your glue will not go all the way into the venous pouch. Your glue will stop dead right there where the posterior choroidal artery interconnects. Likewise, if you were to inject from here, your glue will not reach all the way into the shunt, but will stop dead right here, because this is where the subcallosal artery goes in. So you need to go past the point where your two vessels, or multiple vessels, are converging. And sometimes you really see kind of a network of vessels that are surrounding the pouch, and you will have to go as far distal as possible in order to be able to deliver your glue into the right spot, i.e. the distal portion of the artery together with the proximal vein. Here we see nicely this 3D reconstruction from here, the persistent limbic arch. The subependymal arteries, again, are not good feeding vessels for embolization, and they may take over the supply if you are only ligating, and they will regress if you are taking the high flow shunt away. The nidus of a vein of Galen arteriovenous malformation has to be located in the midline. If it's off midline, it's not a vein of Galen arteriovenous malformation. It should receive bilateral supply, and there is, of course, a spectrum, but the broad categorization is into choroidal types and mural types of niduses. The mural type nidus is a direct fistula, whereas the choroidal type is a more primitive condition where all of the choroidal arteries are involved, and where prior to getting into the vein you have a network of abnormal vessels. And this interposed network before opening into the large venous pouch again will be of importance to you from a treatment perspective, because this means that in these types of diseases, the choroidal types, you should not be able, or you cannot do a transvenous approach, because you have to push your devices all the way back into all of these choroidal arteries, whereas in these mural types you could theoretically do transvenous or combined transarterial transvenous approach with kissing catheters, i.e. one catheter coming from the arterial side into the vein, the other catheter coming from the venous side into the artery, and then starting to coil the most distal portion of the artery together with the proximal portion of the vein. But this, of course, does not work in the choroidal types. And while the mural type and the choroidal type are two extremes, in most cases you have something in between where there are kind of fistulous components, but there may also be a couple of nidus type components. Regarding the venous drainage, for the venous drainage, you will need to not only look at how the shunt is draining and what effects the shunt drainage have on the normal veins, but you also need to look at how the brain drains now. Because remember, your normal internal cerebral veins do not hook up to the vein of Galen in most cases of vein of Galen arteriovenous malformation, and so you'll need to have alternative pathways for the drainage of your brain. And these alternative pathways have been coined the epsilon of the venous drainage. You can see here the Greek letter epsilon, and this is your internal cerebral vein that goes towards the basal vein of Rosenthal, into the lateral paramesencephalic vein, and from there into the superior petrosal vein and outward. So this is your alternative drainage if you have a vein of Galen arteriovenous malformation. The second alternative drainage is indicated here in a patient who has actually no functioning straight sinus. You see that the internal cerebral veins are draining towards the superior sagittal sinus via medial parietal vein. So this is the second alternative drainage pattern. And then the third one could go via subependymal veins towards the choroid plexus here. The veins do not like to be arterialized, and there are two theories that try to explain why, in particular in babies with high flow shunts, we will get what Pierre coined jugular bulb dysmaturation, or what could also be just called like severe stenosis or even occlusion of the jugular bulbs. And this is related to either true intimal proliferation due to the high shear stress forces of the shunt. The second theory is more bony theory with disruption of the skull base development. No matter what the theory is, we do see in patients with high flow shunts, including vein of Galen arteriovenous malformation, jugular bulb narrowing. And then we are in real trouble, or the child is in real trouble. Because in the moment where you have jugular bulb stenosis, now the brain and the vein of Galen arteriovenous shunt have to drain via alternative pathways. Now, the body tries to protect the heart by doing this jugular bulb stenosis, because the more jugular bulb stenosis you have, the less of a cardiac overflow you have. So in patients with jugular stenosis, you have the paradoxical situation that from a clinical perspective, they may be getting better because their cardiological function improves. But now the brain is in trouble, because now the brain has to compete against the drainage of an arteriovenous shunt. In your normal veins, you will have a higher pressure, and this will lead to venous backflow. And therefore the question is, how can the brain drain now? And the best way of the brain to drain is then via the cavernous sinus and out. And this is a concept that you now need to discuss, because this drainage pattern is not present at birth yet. It develops later, and this has been coined the so-called cavernous capture. Cavernous capture means that the cavernous sinus in the newborn is not yet connected to the sphenoparietal vein, and therefore cannot be used to drain the brain. It is only at month 3 to 6 that the cavernous sinus captures or annexes the sphenoparietal sinus and then can be used to drain the brain. And then you will be able to see that the majority of the brain drainage is going through the cavernous sinus via the superior ophthalmic vein, the inferior ophthalmic vein, the vein of the foramen ovale, and the inferior protrusal sinus. So your cavernous sinus has captured, it has saved the brain drainage in this patient here with a maximal stenosis of the jugular bulb. And you will see that these patients will develop those spider-like vessels over their face. This is actually a good sign because it indicates that the cavernous sinus has taken over the drainage of the brain. Now, how do Weber-Gehlen arteriovenous malformations become symptomatic? It depends on the age group. In the neonatal age group, patients become symptomatic with high output cardiac failure. This is when the baby was born. This is just 2 days later. You see the massive dilatation of the heart and the cardiac failure. And therefore, patients will have tachycardia, they have difficulty feeding because they cannot breathe very well, and they can develop multi-organ failure. So this is the way that a neonate will present, and it will indicate to you that there is an extremely high flow shunt present. And if a patient becomes symptomatic this early on, treatment is already indicated in the very early stage. Patients can get worse during the first week of life due to a variety of reasons and can further decompensate with infections. The second way that neonatal Weber-Gehlen arteriovenous malformation can become symptomatic is by true arterial steal. You can see in this patient here that we have diffusion abnormalities over the occipital and the MCA territory. This is not a vascular territory. This is PCA here, and this would be MCA here. So why do we have this type of vascular territory ischemia? It is due to a true steal, which means that all of the arteriovenous or all of the arterial flow is rushing into the area of least resistance, i.e. the Weber-Gehlen arteriovenous malformation, and blood is no longer going towards the normal brain. And therefore the normal brain is crying for help. And it does so by maximally dilating your MCA branches. So if you see dilated MCA branches, that's a sign for beginning steal. And then if the steal gets manifest, obviously you will have ischemia. This also tells you something about what to tell your anesthesiologist prior to treating a baby with a Weber-Gehlen. Do not lower the blood pressure, because if the blood pressure is being lowered, then your brain will actually get even less of the blood, and the ischemia will be even worse. And this is an example here of an unfortunate child that already had some ischemia here, which indicates that you have true arterial steal. We also see massive dilatation of your MCA branches, more on the right side than on the left side, indicating that they try to get as much blood as possible. And if you then have, for a prolonged period of time, lowered blood pressure, you can actually get into this type of scenario here, where despite a successful embolization, the child actually died and had massive ischemia over both cerebral hemispheres. And you can see it even on the diagnostic angiography. If you see that all of the flow is going into the shunt, and there's this sluggish filling here into MCA branches, you know that there's not enough oxygen coming into the brain. So paradoxically, in these patients, you have to actually increase the blood pressure when you induce anesthesia, rather than decreasing the blood pressure. It has been coined melting brain syndrome. However, I believe it's truly related to hypoperfusion type or low perfusion pressure issue. Okay, if the child survives the first couple of months, or if the flow is not so bad as to present with cardiac manifestations, then the children may actually remain asymptomatic or remain undiagnosed until they are 1 year old, 2 years old, and in these age groups, the manifestation will not be with arterial steal or with cardiac output failure, but with hydrodynamic disorders that Alan described, developmental delay, seizures. Hemorrhages are very rare in vein of Galen. So what do I mean with hydrodynamic disorders? You've heard from Alan nicely that how the CSF is like not only reabsorbed but is moving through the brain, including the absorption of the CSF via medullary veins. However, if your blood pressure in the medullary veins is increased, i.e. if you have venous hypertension, this will lead to a decrease in CSF reabsorption and therefore an increase in ventricular size. And this increase in ventricular size is, as you can see in this example here, regressive in the moment where we are treating the arteriovenous malformation. This was before treatment, this is after treatment, and the ventricular size goes immediately down because you have less venous hypertension and therefore the brain can better drain via its medullary veins. Shunting is not a good idea. You can see here what happened after a shunt was placed. In fact, the vein of Galen now increased or got inflated. Or you can have subdural hematomas, in this old case from Pierre, when you put the shunt in. So don't put in the shunt. Same thing with the tonsillar prolapse. Just as Aaron explained, it's not a problem of mass effect. You have here like a humongous vein of Galen malformation that is, however, thrombosed following treatment. There's no evidence for tonsillar prolapse. There's here a relatively small vein of Galen pouch, but not yet treated, and therefore you have the venous hypertension, which will lead to tonsillar prolapse. And here you can see that this is something that develops over time. This is the same patient just a couple of months later. And it is regressive after treatment, as you can see in this example here, where the shunt is now completely occluded and the tonsillar prolapse is spontaneously regressive. Why can these patients also present with a developmental delay? The developmental delay is related also to venous hypertension. Venous hypertension can lead to congestive edema and then ultimately, over time, to first a damage of the white matter and then a paucity of the white matter, as you can see in this example. And this can lead to developmental delay that can be tested out with, for example, here the Denver test for how a patient develops. Seizures can be present in patients, in elderly patients with vein of Galen malformations, i.e. after the age of 2 to 3 years. Due to the long-standing venous hypertension, you can get calcifications in the brain, and these calcifications, here 4 different patients with massive calcifications each, all of them had a vein of Galen arteriovenous malformation, are epileptogenic and therefore can cause seizures. And of course, if you have this type of pattern, there's very little that you can do from a treatment perspective. This child will not do fine, no matter what you're doing. In a way, the window of opportunity has passed in these 4 patients, and they will have a significant psychomotor delay and seizures for the rest of their life. So here, just some example of these calcifications related to the severe pseudophlebitic aspect. Hemorrhages are rare and only happen if we have a reflux of your arteriovenous shunt into the pial veins. As we can see here, this is in the moment where you have therefore this venous hypertension into pyruvate, potential risk for hemorrhage. How to diagnose vein of Galen? Most of them nowadays are diagnosed in utero, and therefore we have seen a significant decrease in vein of Gales, at least in our institution, because lots of them are, lots of the children are unfortunately terminated in utero once the diagnosis is made. And in our opinion, this is not can be very controversially discussed, because there are now treatment options present for these types of malformations. So here we have a fetal MRI that demonstrates a midline vascular malformation. We don't see yet any abnormality within the brain, so there's no evidence for ischemia. Looks like a neural type, i.e. a fistulous type. So the diagnosis can be done with fetal MRI, with fetal ultrasound, as we can see here. And postnatally, we can see, obviously, both with ultrasound and with MRI, the vascular malformation in these cases. Remember to also look at the chest and to do a complete workup for the kidneys and the lungs and the liver to ensure that you don't have multi-organ failure. I like, for vein of Galen, arteriovenous malformation, to go methodically through the images. I have to identify whether the brain parenchyma is still normal, because if we see significant abnormality within the brain parenchyma, there may not be a salvation for the child, and therefore always look at the status of the myelination, the presence of brain atrophy, ischemia, DWI abnormalities, look at calcifications. Is there hydrocephalus present? Do you have tonsillar ectopia? Are the MCA branches dilated? If the MCA branches are dilated, you know that you have arterial steal. Look at the pattern of arterial feeders. Do you have secondarily recruited vessels? Is it a choroidal or mural type? Rule out mimicus. And do you have thalamoperforating arteries recruited? Because this will make your life more difficult. On the venous side, look for venous outflow obstruction, i.e. you need to have not only a good arterial time of flight MRA, but you also need to have a venous, for example, phase contrast angiography to look at the status of the maturation of the jugular valves. Is there evidence for cavernous capture? Do you have a pseudophlebitic pattern? Do you have venous reflux? Because all of these findings will then give you an indication to treat. Our therapeutic strategy is that first, in the neonates, you have to ensure normal development, i.e. the first thing that you have to do is reduce the cardiac overload if the patient presents with high output cardiac failure. And the second goal has to be to reduce the venous congestion. And these goals will now also tell you when to stop with your embolization, because we rarely are able to cure vein of Galen, especially a choroidal type, within the first session. And it's not necessary. I typically stop my embolization if in the moment where I don't see any longer reflux into the superior sagittal sinus from the fistula. If there's still a reflux into the superior sagittal sinus from the fistula, I will still continue to treat the patient because there's too much venous congestion. So that's my angiographic sign. Very early on, we try to keep the patient from being treated, because the smaller the child, the higher the risk for the treatment. So we try to buy time by using all of these medications to permit normal oral feeding. Neonates are only treated if they have medically refractory heart failure. Most cases are now treated, actually, this is what I used to say at the age 4 to 6 months, we try to treat them now a bit earlier at approximately 3 months of age, and we treat earlier if there's a decline in cardiac function or beginning hydrocephalus. Pierre developed the so-called Bicetre neonatal evaluation score that can be found in multiple publications, where he gave points depending on the cardiac status, the brain, the pulmonary status, kidney and liver status, and depending on the score, he developed these indications and timing for endovascular therapy. If the score is really bad, or if there's already signs for brain damage, there's very little that we can do. The window of opportunity has passed. We will not be able to save this child. We treat as emergency with a score of 8 to 12, or if there's cardiac failure with otherwise good scores. And we treat these ages depending on whether the patient deteriorates. Together with Carol, we looked at our data as predicting factors for good or bad outcome, and obviously the neonatal Bicetre score is one major determinant of outcome, but also whether or not there is already evidence for brain damage. If the patient has a calcification, the likelihood of a good outcome is extremely low. So we withhold treatment in these types of scenarios here. Massive steel, already evidence for calcification, paucity of the white matter. That's, I think, not a good case to treat. If you have a very poor prognosis and a combination of multiple of these factors are indications to withhold treatment. We perform a treatment in the emergency setting when we see dilatation of MCA branches without yet flare or DBWI abnormalities, because this is a sign of arterial steal. And you can see that we treated the patient, but despite our efforts, outcome was so-so. I mean, she did have a significant developmental delay. So these are our indications for emergency treatment. Conservative management, a total of like the 72, I think, vein of Galen arteriovenous malformations that I have seen over the last 14 years. Conservative treatment was done in 3 of them, and all of them had the same imaging features. They had evidence for beginning thrombosis, i.e. T1 methemoglobin signal within the pouch, at the first images. And you can see here that this patient cured her vein of Galen arteriovenous malformation by herself. So a very selective group that have to have very good neonatal scores, and where you have a low flow shunt and beginning venous thrombosis. These are the cases where you can do conservative management. The majority of cases are of course treated, and our main limitation is arterial access and contrast limitation. Therefore, we are now having changed our practice a bit. If we have an in utero diagnosis of a vein of Galen, we typically have the child, when the child is born, we keep the access through the umbilical cord patent for the first couple of days to be able to treat through the umbilical cord if the patient develops cardiac insufficiencies. Okay, how do we treat? If we are not able to, if we are not using the umbilical cord, this is the way that treatment is done. We keep the vessel pinched between our both arteries, because in the neonate, one of the main problems is that the vessel moves a lot in the subcutaneous fat. So keep the vessel pinned between your 2 fingers here. The flow is often not very high, as you will be able to see now when we are slowly pulling back. And this is due to the case that the patient often have cardiac insufficiency, so there's often only a little bit of a trickle going on, and you may not be sure whether it's artery or vein. Look at the color of the blood, which will allow you to know this is artery. And then we put the 4 French sheath in. Do remember that the longer the procedure, the higher the likelihood for the artery to actually thrombose off. And then some of the children will develop over time atrophy of one leg over the other leg, and this is something that you should avoid. So we try to be not too long in the vessel and try to be actually fast with the intervention. For diagnostic purposes, we use a 4 French catheter. The treatment is depending on the fistula done with a Baltacci and pure glue. And following the procedure, the child is being put into a decleaver position to get better outflow and to prevent venous thrombosis. And here is now an example for the glue injection in real time. We are very close to the fistula. Here's the arteriovenous transition, and you try to make like this type of mushroom type embolization where you take the most distal artery together with the proximal vein here. And these are high flow fistulas. You can see that one of the nice things of glue is that it's thrombogenic. This was after the first session, and this was the same patient without any further treatment or follow-up. The vein of Galen had completely occluded because of the high thrombogenicity of the blood. We see here our position of the microcatheter, fistulous component, and here's the glue cast. And again, the mushroom shape, you see that you are from the artery all the way into the vein. And despite there being still some flow, we would stop in this case here. You see that prior to embolization there is reflux into the superior sagittal sinus. After embolization there is no longer reflux, therefore the brain is not being tempered with any longer. We see also better flow now in the cerebellum, less venous congestion, and we see that the blood pressure is actually getting higher, which indicates that the cardiac function has ameliorated. And in this moment we can stop our treatment. Don't get overly greedy. If you inject too much, then you can have overshooting thrombosis with all of the veins closing up on you. So therefore, we like to stage our treatment. Here we have at the beginning of the treatment, you see venous reflux into the superior sagittal sinus. You have significant congestion in steel. This is at the end of the first session. This is at the end of the second session, and here at the end of the third session, patient was treated. This patient here we treated over 5 sessions here, finally leading to complete obliteration of the shunt. You will be able to see immediately after your successful embolization that there's better perfusion of the brain, of the cerebellum here after the vertebral artery injection. And here another example where following treatment you first go for the highest flow shunts and then slowly work your way down. And this is before and after treatment of this patient. Venous approach do have a higher morbidity, especially in the vein of Galen arteriovenous malformation that are choroidal in nature. In fistulous ones you can use it, but your goal always has to be to take the artery with the proximal vein, not only the vein itself. Follow-up is extremely important with MRI, where you need to look at indications to perform more type of treatment, especially if you're not completely obliterating the first session. Depending on your venous drainage, you can have different type of clinical presentation with macrophrenia, macromedullation, depending on whether or not there's reflux into these structures. So looking and evaluating the vein is extremely helpful or important for the management of vein of Galen. In our opinion, the antenatal diagnosis is not an indication to perform early delivery, interruption of pregnancy, or C-section. Diagnostic angios are not indicated. If you do an angio, do also the treatment. The veins are the key to understand and treat this disease. Transarterial embolization is, in our opinion, the therapy of choice. Don't go for femoral punctures because you will take your access route. Don't go for jugular central lines because of the possibility of venous thrombosis. And if the child has a thrombosis of his vein, then the brain doesn't drain any longer. And of course, no epicranial lines. There is no room for error, which means that, in my opinion, these types of diseases should be centralized, i.e. performed by an experienced group. The UK, for example, every single vein of Galen in the United Kingdom goes to the Greater Ormond Street Hospital. I think that this is a good idea because these are rare and challenging diseases. You have to have a good team of physicians, and you need to follow the patients closely. And with this, I would like to thank you very much for your attention.